We've been pretty dismal in our support of global cancer, actually. We put hand on heart and look at the amount of money we have transferred into building capacity, training fellows from countries, supporting IARC in delivering cancer registries, 15 million. You know, we give that as a single fund to a grand challenge, and yet they're going around with a begging tin. It's really embarrassing, frankly.
So high-income countries fund and support healthcare in a variety of emerging and low-income countries through development assistance for health and through overseas development aid. The reality is, though, that they don't correspond very well to the priorities and the realities on the ground of many of the emerging and low-income countries. Less than 2% of development assistance for health is actually directed towards non-communicable diseases, and even less than that would actually go towards cancer. There just isn't a specific focus on cancer that there really needs to be, because it's a major systems challenge for nearly all of the low-income and emerging economies. Development assistance for health needs to radically improve to start engaging and enveloping cancer as a major domain, but also about building the systems to collect the data on cancer burden and cancer outcomes at a hospital and a community level that are going to be really essential to have rational national cancer control policies. And more broadly, develop the capability and capacity of the workforce. The workforce is absolutely critical. In surgery, pathology, delivery of chemotherapy and radiotherapy, it's very easy to buy equipment and build new hospitals. What takes a lot of time is to build the workforces necessary to deliver complex cancer control. There are over 111 different surgical procedures, for example, for cancer. Individuals who have the expertise in cancer pathology, radiotherapy, and indeed in medical oncology and palliative care as well. We need to find additional funding. Individual countries who put money into overseas development aid need to have cancer as part of that budget. A lot of the money that flows in is very narrow. It's still very much vertical programming. And that needs to really radically change to reflect the priorities, particularly in cancer, that these emerging and low-income countries have. Cancer research and cancer capability and capacity is an incredibly well-funded endeavour in high-income countries. There are vast sums of money flowing around that are just not making it to support low-income and emerging economies. Many of the big institutions and research funders need to start looking at how they can start almost maybe a donation, a tax from the individual major efforts that they're engaging in for high-income research. Something as simple as a sort of 5% dividend that flowed overseas to support those sorts of countries would make a radical difference, because it would support areas such as vital statistics, registries, that are simply not a sexy area for most of the funding that's coming through now. A further challenge as well to a lot of countries around the world, and something that high-income countries have never experienced before, is this problem of de-development. Nearly a quarter of the population on the globe now lives in or is affected by conflict in some form. It's pushing refugees across borders and boundaries who are ending up in countries and causing major de-development. So places like Syria and Libya that used to have very good outcomes for their cancer patients have gone completely backwards. It will take 50 years or more of concerted effort to rebuild their cancer control systems. But the refugee problem as well, as refugees settle in places like Jordan, Turkey and Lebanon and are absorbed into domestic populations, puts a huge impact and burden on those particular countries to deliver cancer care. And this is a huge challenge that high-income country donors simply have not stepped up to the plate yet about and understood.